I'm Peter Block here at TCT 2018, and one of the questions that always has bugged interventional cardiologists is what exactly do we do with a severely calcified lesion? Do we rotablate? Do we use a cutting balloon? Do we try to put a regular balloon in? On and on and on. We have very little data. But with me is Gerd Reichert from Bad Siegberg in Germany, who has just told us about the Prepare-Calc, C-A-L-C, which is German for calcium trial. So tell me about the trial, and then we'll get to what the outcomes were. But this is sort of a fascinating trial.
Thank you. I think this is a trial which is of interest for most of the interventional cardiologists because we see more and more patients with severely calcified lesions, and we have very poor data how to treat them. A lot of ideas, but no evidence.
Exactly.
So, yes, and we randomized patients with these characteristics into a group which received an upfront rotablation and another group which was treated with cutting or scoring balloons.
Okay, so you split them 50-50.
Yes.
And was there some kind of way to bail out if one didn't work?
Yes, yes. We had a crossover option, which is obviously always reasonable. You can't stop the procedure if you haven't done it. And this was one of the main findings, that in the balloon group, at least one of 5 patients had to cross over to the rotablator. And this was the driving point for the primary endpoint strategy success, which was significantly different in favor of the rotablator.
And that is because of the crossover issue?
Mainly because of the issue, yes.
So if you take all of the patients,
yes,
and you say, okay, I'll start with a relatively non-invasive cutting balloon or scoring balloon,
yes,
and then switch over, what are the outcomes if you have that switch? Were they even?
Yes. If you look at the whole cohort, they were even in terms of clinical outcomes, late lumen loss, and all the angiographic parameters that we have investigated. And the bailout issue is obviously not a big problem for a patient who has a crossover to the rotablator.
So let me ask you a question. If I'm doing your intervention and you know you have a severely calcified LAD lesion, what are you going to tell me to start with?
I would look at the lesion. If it is very severely calcified, if there's a lot of stenosis in a long lesion, and if you are a gentleman, then I will start with the rotablator, because we found in the subgroup analysis that females had no profit of the rotablator.
And that is because their arteries are smaller, or why do you think that is?
They have less calcium, that is what I guess.
And they have less calcium as well. Okay, so give the folks out there a take-home message, all the interventionalists out there with a severely calcified lesion, what would your strategy be?
I would say if you want to be a high-quality calcified lesion operator, then you should have a lot of experience in rotablation. And depending on your personal preference and some particular issues of the individual patient, you can start either with a rotablator or you can start with a balloon. But finally, you have to do the job with the rotablator if the balloon doesn't work.
Okay, so the answer, I guess, is really you need to be able to do both.
Yes.
And any good interventionalist with a calcified lesion ahead of him needs to have multiple tools at his beck and call.
Yes.
Thank you.